guys? Okay, so now we're coming to the last part, which is the blood supply. And remember that I told you guys the whole story about the blood supply, and I'm sure now it's very easy for you to recall. We talked about how the vertebral arteries are gonna have unite together to form the basilar. It's gonna give the pica, and themselves they are going to supply the medulla, and from the basilar you have something called pontine branches, pontine arteries. They're gonna supply the pons. So the basilar is gonna supply pons, and the ica itself is gonna supply pons, and then it's gonna end up as superior cerebellar, and then the terminal branch is the posterior cerebral, and they are going to supply the midbrain. Okay, so for pons we have the ica mainly and basilar. Okay, so if you look at pons, you can see that the ica is basically supplying laterally, and the basilar, the baramedian branches, are going to supply the medial part of the pons. So posterolateral part, like we said, are supplying the bi-ica, and the basilar is giving you the paramedian branches here. Okay, so the ica is basically supplying posterolateral part, and also the superior cerebellar artery is going to supply. Okay, but mainly ica and basilar. Now, what's gonna be the injuries, the vascular problems that we can have in pontine? Remember, you guys, I told you we have a golden phrase when it comes to the vascular lesions of the brainstem, and we started our talk about that when we said the medial medullary syndrome. It has something called alternating hypoglossal hemiplegia, and we said in that we have contralateral. If I have a problem here, I'm gonna have contralateral in my body and ipsilateral in my tongue in the medial medullary syndrome. I have the same thing here, and that is called the Miller-Gobbler syndrome. In the Miller-Gobbler syndrome, it's a problem in the medial part of my pons, and in that I'm gonna have the same golden phrase. But remember that the cranial nerve, the very famous cranial nerve nuclei related to your pons, is not the hypoglossal like the medial medullary syndrome. Here it's the abducent and facial. So what we'll have is we're gonna have alternating facial and abducent hemiplegia. What does that mean? It means I will have ipsilateral, abducent and facial nerve injury, and contralateral hemiplegia in my body. Okay, so if I have a problem in the pons, I will have contralateral hemiplegia in the body, and ipsilateral facial and abducent. What does ipsilateral facial mean? It means, you guys, the lower motor neuron lesion that I talked about it in the previous slide. It's a lower motor neuron, because here this is a lower motor neuron lesion. If we have a lesion in the pons, it means the cell bodies of the final electricity is there. It means this is a lower motor neuron lesion, and even the abducent. So what would happen to the abducent? It's a paralysis of the lateral rectus muscle. Okay, so what's gonna happen to the facial nerve? It's a lower motor neuron lesion. It means what? It means ipsilateral facial nerve paralysis. The whole half of the face is gonna be lost, because the final electricity of the half of the face is lost ipsilaterally. All right, so this is what we're gonna have in Miller-Gobbler syndrome. I can also see here the medial lemniscus is affected, so there should be a proprioceptive sensation loss. Okay, so what will happen in the cerebellopontine angle? Remember, we said that we will have something called acoustic neuroma, and that is going to affect the vestibular nuclei. Other than that, remember that these are the most important things you have medially. Okay, and the motor stuff is here. Okay, because here you have the corticospinal tract, so that's why you will have contralateral hemiplegia. But here, think about all the sensations you have and things that are laterally that we talked about, that we ever talked about in pons. What are they? Remember, 5, 6, 7, and 8. All right, so 5 is the trigeminal. You will have a problem with the trigeminal sensory and motor nuclei, and we said the lesion previously. You have a problem with the facial, and we talked about what will have in lower motor neuron facial nerve paralysis. You'll have a problem with the vestibular nuclei, which is vertigo, all right, deafness, because you have a problem with the cochlear. Hyperacosis. Why hyperacosis? Because here, you guys, we have a muscle called stapedius, and that muscle is supplied by the facial nerve, And that muscle is actually important because it holds, we have 3 ossicles in the middle ear, and these ossicles, when you hear with your ear, you have sound waves. They are going to, of course, this is explained in details in the ear videos, but I'm gonna just give you a brief idea about that. The sound wave is going to cause these ossicles to move, and then that will move the fluid in your ear so that you can hear. The stapedius muscle is attached to the stapes bone. This muscle is important so that if there is a very high noise outside, it's gonna contract to reduce the oscillations so that you don't hear a lot of noise. If you have a paralysis in Fission nerve, which supplies the stapedius muscle, this is not going to happen. So they are going to move without any control. And I cannot now contract and reduce the amount of oscillations reaching my inner ear. So everything is going to be very, very, very noisy. I'm going to hear even the unneeded kinds of sound. So this is what we call the hyperacosis. All right, so these are the lesions that we have here. Thank you guys for watching, and see you in the next video.